Okay, Assalamu alaikum and good evening. So this is one of the first lectures of the conceptual basis of urology course, which we're going to start off from first week of from the first Saturday of January, and it will continue throughout the year on the first and third Saturday of every month. We'll have speakers from all around the world with sessions and panelists covering most areas of urology. So as a first preliminary talk, I'm going to talk about managing complication following open radical cystectomy and orthotopic neobladder. Feel free to ask questions right in the chat box, and I will try to address them throughout this meeting, throughout this presentation, and subsequently we'll try to do it in the end as well if there are any further questions. So we know that radical cystectomy is the treatment of choice for patients who've got organ confined or locally advanced prostate cancer, bladder cancer. So it is T2 to T4A and not MX disease. There's some other indications of radical cystectomy, which includes recurrent high-risk non-muscle invasive bladder cancer. And we'll share a few cases to clarify these indications. In particular, patients who've got BCG refractory or BCG relapsing bladder cancer, and these are particularly important group because they have a high risk of complications if cystectomy is delayed. Sometimes you have extensive papillary disease, which cannot be controlled with TUR alone. And unless you do a complete TUR, the intravesical therapy is not very effective. Then there are some non-muscle invasive bladder cancer with variants, and these variants are really not amenable to the intravesical treatment. So these are some of the indications for cystectomy in non-muscle invasive disease as well. So this is really, cystectomy is the gold standard for all these situations. Just to have a quick revise of the anatomy. So we know that tumor which is non-invasive, which is not going into the mucosa, are TA cancers. T1 is the one which is crossing the lamina propria, whereas T2 is the disease which goes into the detrusor muscle. And if it goes beyond T2 into the perivesical fat, it becomes T3, which is microscopic as T3A, and gross involvement is T3B. If it goes to the perivesical tissue, like prostate in men, and it is T4A, and if it goes to the pelvic side wall, it's T4B. So let's start off with the case, and this is this gentleman initially presented in 2013. He's a landlord, 64 years of age at that time, smoker, diabetes, and he presented with hematuria. At that time, a CT was done, and it was tumor in the bladder. He had a TURB, which showed a urothelial cancer, which was invading the lamina propria, but it was not going into the muscle. It was high grade. So he received 6 cycles of BCG induction, is followed by 2 years of maintenance, and that was, in that time, 1 to 2 years was what was recommended. So after 2 years of maintenance, he was on regular surveillance cystoscopy plus urine cytology until December 2019. You know, that's the time where the pandemic really hit, and the oncological patients really suffered because of irregular follow-up during that period. So he was lost to follow-up. He came back in April 2021. And at that time, his cystoscopy was fortunately unremarkable. However, soon after, he presented again with cytology showing that there are few scattered clusters of atypical urothelial cells. At that time, his cytology was positive, not positive, intermediate, whereas his cystoscopy was really unremarkable. He underwent angiography and angioplasty in between, but again then developed hematuria. And at that time, an ultrasound showed a large growth on the left lateral wall of the bladder, which was a bit surprising for us because the January cystoscopy was clear. So he underwent another TURP, and unfortunately, he had a significant bladder growth on the left lateral and the posterior wall, which we initially did a block resection of the tumor. It looked papillary, but then once we start removing these papillary growths, and there are 2 or 3 of them on the left lateral and posterior wall, there was some element of a solid growth as well, which was also removed, and biopsies were sent from the muscle. And as you can see, that in this arm block resection, these muscle fibers are actually visible. So the pathology came out to be a high-grade tumor, which he had to start off. But this time it was going into the muscles. So it's a PT2. You can see these muscle bundles which are heavily invaded by the tumor. Now he's in his mid-70s and with a slightly raised creatinine and obstructive uropathy on one side. And as you can see in this PET scan images, that there is a hot area so there is a hot area here. I wonder if my laser pointer is visible. So this is a hot area here, which is related to the common iliac. There was a tumor in the bladder, which is going into the extravesical space. The left kidney was obstructed with hydronephrosis. And this is the extravesical disease, as you can see here, with a hot spot on PET scan related to the common iliac lymph nodes. Okay, so that's a clear indication for radical cystectomy, and any delay in performing this procedure is going to be detrimental. So he did underwent a radical cystoprostatectomy with an ileal conduit, and we're still waiting cystopathology, and he made an unremarkable recovery and was discharged 5 days after cystectomy. This is another case, a 63-year-old male, 30-pack hair history, large volume bladder tumor. He had 2 resections. And after both, we were unable to clear him completely. This patient had significant solid sessile tumor, again in the left lateral wall, but then again also elsewhere. And as you can see, that this is on the second time that we are going in, and there's still plenty of tumor left. We removed some of the tumor using the arm block technique. However, the bigger tumors on the lateral wall were taken care of using the regular piecemeal approach. So all these tumors were resected, but still we were not able to clear his bladder of all the tumor. What was the option of treatment in this patient? Either you do a redo TUR, you do external beam radiation therapy or BCG, or do a radical cystectomy. So the pathology comes out to be high-grade non-muscle invasive bladder tumor, and the muscle was sampled and it showed no disease. So what are the options? Kindly write down in the chat box, and we'll talk about your answers. and what is the correct approach. So this is another case, and as you can see, this is a large bladder tumor in a 56-year-old male with a history of tobacco consumption, about 25 years. It was a isolated 4-centimeter tumor on the posterior lateral wall on the left side, and it was completely resected. However, he continues to have positive cytology, and he underwent another TUR, which showed that there was tumor in the close to the prostatic ducts and in the prostatic stroma, and this makes it a little more complex. So what are the options of management in a patient who has a large papillary urothelial cancer with histopathology showing T1 high-grade cancer with no muscle involvement? Muscle was sampled, and positive cytology and subsequent TUR showed that there is prostatic stromal involvement. So should one go for radical cystoprostatectomy, EBRT, BCG in the prostatic fossa as well as bladder, or deep TUR and BCG? So these are the 4 options. Consider answering these questions in the chat box by writing A, B, C, or D. And again, we will take up this case subsequently. So this is third patient, a 63-year-old teacher who is chewing tobacco for over 40 years. She presented with gross painless hematuria. Complete resection of the tumor was done on the lateral wall on the right side, with the some portion of the tumor on the anterior wall. The pathology showed that it's a poorly differentiated non-muscle invasive urothelial cancer invading lamina propria with a micropapillary variant. Repeat TURBT in 4 weeks also showed that there is no muscle involvement. So what are the options of treatment for this third patient? BCG induction and maintenance, mitomycin C induction and maintenance, systemic chemotherapy with cisplatin and gemcitabine. Her creatinine was normal with both normal functioning kidney, or radical cystectomy and some form of urinary divergence. So case 3, please mark your answers. Okay. Another patient, a 51-year-old gentleman whom we did a cystectomy last month. He presented with gross painless hematuria. His histopathology was interesting. It showed there's a malignant neoplasm and features were suggestive of sarcomatoid cancer. It was organ-specific and immunohistochemical marker of bladder cancer, bladder were negative. So it's important when you have a sarcomatoid tumor that you need to see if it is of bladder origin or from elsewhere. However, extensive workup did not show any other organ involvement. He has got obstructive uropathy bilaterally, as you can see from the scans exhibited here, with significant obstructive uropathy on the left side and moderate obstruction on the right side. A large tumor in the bladder with calcification. So after extensive workup, it was decided to do radical cystectomy, as this patient did not have any other involvement, any other organ. However, it was a locally advanced tumor with features exhibiting, as you can see, this is the regular urothelial cancer, high grade, and this is the sarcomatoid component here. So it's a true biphasic malignant neoplasm with morphological and immunohistochemical evidence of epithelial and mesenchymal. So it's sort of a sarcoma and carcinoma both, and it's an extremely aggressive cancer, and these patients really need to have aggressive treatment, otherwise it can metastasize and cause significant morbidity. So the variants of bladder cancer are many, and some of them are aggressive in terms of their clinical behavior. So the variant histology is associated with worse cancer-specific and overall survival. And the most studied variants include micropapillary, and we have shown you one case of that lady with micropapillary variant. Squamous differentiation, sarcomatoid, we have seen one case of sarcomatoid, and these are consistently associated with high-grade disease. So even if your histopathology is showing that these patients have got non-muscle invasive bladder cancer, in presence of these variants, you really need to do aggressive treatment in terms of radical cystectomy. Unfortunately, systemic chemotherapy, there is very little data to show that systemic chemotherapy works in this situation. This is our own work, reported some years back by one of our ex-resident, who is now a consultant in UK, and this is Kaplan-Meier curve, and you can see that the variants have got the worst prognosis. So majority of the patients have actually died before 2 years, and this is really a bad prognostic indicator, and one need to be really aggressive in treating these patients. Question about radical cystectomy, that when should it be done? Well, it's very clear from a meta-analysis of 19 studies that if the radical cystectomy for urothelial cancer is performed within 3 months, the significant improvement in overall survival is noted. Whereas if it is performed after 3 months, the survival really is negatively impacted. How should it be done? Well, the classical technique of doing a radical cystoprostatectomy in men, along with lymphadenectomy and anterior pelvic exenteration in women is the standard. However, there are genital organ preserving cystectomy as well. However, these techniques should not be offered unless the patient is really motivated and is suitable to undergo these procedures. So it has to be really open confined disease, and with current imaging, it can be easily assessed. And the patient is really motivated for preservation of genital organs. So it's a very rare indication of doing this kind of organ preservation. So in vast majority of your patients, they would have to undergo a radical cystoprostatectomy or anterior pelvic exenteration based on the gender. Whether it should be performed by open or robot assisted, well, there is a lot of enthusiasm these days in literature about robot assisted radical cystectomy. However, you will need to understand that it is a technique which is still evolving. The data so far, which is really about 10 to 15 years data now for robotic versus open prostatectomy, showed that there is 1 to 1.5 hours of longer operating time for robotic procedures. And obviously the cost factor is there. However, there is a shorter hospital stay, which is decreased by 1 to 1.5 days, and less blood loss than open radical cystectomy. So if you look at the most endpoints, including intermediate oncological endpoint and quality of life, they're really not different between open and robot-assisted radical cystectomy. So what really matters is the surgeon's experience and the institutional volume, which determines the overall short-term and long-term outcome in cases of radical cystectomy, whether it is performed by open or robot-assisted. The other important question about cystectomy is concerning the whether neoadjuvant chemotherapy, and we know that from the URTC-MRC trial 2003, there is strong evidence that there is 5 to 8% 5-year survival benefit in patients who undergo radical cystectomy and have received neoadjuvant chemotherapy. So in situation, it is helpful, but not in all cases. We need to remember that patients, that this data is coming from the MVAC times. So MVAC was the treatment at that time for this cohort of patients on which this RCT was based. And now MVAC is hardly used, so we use cisplatin gemcitabine combination. The second thing is that close to about 40 to 50% patients are not responsive to platinum-based chemotherapy. So it's a waste of some important time, and we know that cystectomy delayed can result in negative overall impact. The other thing is that sometimes patient becomes sick after neoadjuvant chemotherapy, and that can also delay treatment. So it has to be really tailored and based upon the patients when you take a decision about the use of neoadjuvant chemotherapy. So the recommendation from the EAU guidelines 2021 is that offer neoadjuvant for T2 to T4A and not bladder patient, and it should be cisplatin based. So patients who are ineligible for cisplatin because of cardiac reasons or because of creatinine should really not undergo any neoadjuvant treatment and should have direct radical cystectomy. The current role of neoadjuvant immunotherapy is in trial settings, and that should not be used. And there is a strong evidence against that. Well, lymphadenectomy is an important part of radical cystectomy. And the standard lymphadenectomy is indicated for all patients. So there is no role of limited lymphadenectomy. As you can see in the video, that this is the angle of Martial, or the division of the common iliac. And that forms the cranial limit of the section. You can see the external iliac artery, the space between the external iliac artery and vein, the internal iliac artery and its divisions. And all these lymphatics are removed from this area. Going medially, you can find some median sacral vessels related lymphatics. Those should be removed as part of the standard packet. Laterally, you go up to the genitofemoral nerve, and inferiorly, you go up to the lymph node of Cloquet. This is obturator fossa. You can see the obturator nerve clearly, and all the obturator fossa related lymph nodes should also be removed. If there is any indication, extended or super extended lymphadenectomy can also be performed. So there's data indicating that there will be therapeutic advantage in patients who undergo good quality lymphadenectomy. Right. Now, complications are seen in significant proportion of this complicated surgical procedures. And overall complication rate is it's about 1 in every 4 patients has some form of complication in the first 3 months. In the first month, and about 1/3 have a complication in the first 3 months. The difference between limited and extended lymphadenectomy complication rate is slightly higher, with lymphocyte requiring drainage after extended lymphadenectomy is slightly higher compared to the standard lymphadenectomy. The lymph node yield is also significantly higher if you do extended lymphadenectomy. And the Penta Factor described for radical cystectomy includes that you should remove at least 16 lymph nodes to be able to indicate. This is our paper done some years back, and it showed that if you submit your lymph node packets as separate, so for example, external iliac lymph node packet, the internal iliac lymph node packet, and the obturator fossa from the right and left side. So rather than sending them right and left side lymph nodes, you send them in 6 different packets. The lymph node yield increases. However, it has a potential for increase in the cost of pathology work, related cost as well. So if you send them 6 rather than 2 samples. So the review that we have published many years back indicated that for T3A2 and positive patients treated by radical surgery will have progression in 5 years, and 50% would progress. So it's important that one has proper staging information in terms of nodal stage, and these patients probably would require adjuvant treatment unless, so patients who've got nodal positive disease would have poor overall 5-year survival. So what's the Penta Factor for radical cystectomy? Well, it should be negative surgical tissue margin, that is number 1. Number 2, that you retrieve at least 16 or more lymph nodes. There is absence of recurrence within the first year. So absence of clinical recurrence within the first year after surgery is another point in the Penta Factor. And the 5th one is that there is absence of high-grade complication, which is 3 and 4, 5 complications in the first 3 months. If there is an absence of urinary divergence related complication at 12 months, that's the 5th point in the Penta Factor. So it's a convenient way of knowing what are the standards in performing the radical cystectomy. So this is data from the Mansoura group, and they have found that the factors which influence not achieving the Penta Factor include the ASA grade. So if your patient's ASA score is greater than 3, there is a significant possibility of not achieving Penta Factor. If the patient's BMI is on the higher side, greater than 35, again, that patient is more at risk of developing complications, and as such, they would not achieve the Penta Factor. Perioperative blood transfusion of greater than 4 units was another factor. And patients in their cohort who had an ileal conduit were at high risk of developing complications and then not achieving Penta Factor. So those patients who achieve Penta Factor have a 5-year recurrence-free survival of 81 or 82% compared to 63% of patients who have not achieved the Penta Factor. If we look at another complication of radical cystectomy is the worsening of the renal function after surgery. And the development of functional decline in the kidney function reaching CKD stage 3B or worse, which means less than 45 mils of estimated GFR. At 5 years was seen in 17% of patients in this cohort reported in Urology last month. So The renal function loss, however, is not associated in this cohort with increasing the mortality. And the factors that the authors noted responsible for loss of kidney function after radical cystectomy included lower preoperative estimated GFR, diabetes, patients who have received pelvic radiation therapy and the salvage cystectomy is done. If a continent urinary diversion is performed either in the type of continent cutaneous diversion or orthotopic neobladder, and if the patient develops postoperative urothelial strictures, and all these factors are responsible for loss of kidney function, and they should be specifically looked at. Now, urinary divergence are essentially of three types. One that is on the abdomen in form of ureterostomy or ileal and colonic conduits of various forms, and these are incontinent diversion. And these are the commonly used diversion types. Then there is urethral diversion, which is in the form of orthotopic neobladder, and rectosigmoid diversion, which are very infrequently performed these days because of the various long-term complications, short-term and long-term complications. This is an editorial that I have written some years back in European Urology, and we concluded saying that patients should be well informed about various types of diversions and a preference. So not all patients are happy with orthotopic neobladder, which is considered as a ideal type of urinary diversion. So people should be informed about various options, including both incontinent, and orthotopic divergence. The decrease in the complication rate after with divergence really depend upon, like rest of the steps of radical cystectomy, is patient, the hospital volume and surgeon's volume. The complications related to radical cystectomy orthotopic neobladder is noted the perioperative mortality seen in about 1 to 3% of patients first 3 months, and 2 to 8% of patients in first 3 months. So if you look at the 3-month complication rate, more than half of the cohort have some form of complication, and the late morbidity was usually linked to urinary diversion rather than cystectomy itself. So cystectomy-related complications are typically in the earlier period, whereas long-term complications are really related to urinary divergence. If you look at the continence, the diurnal continence is in about 90% of patients, and nocturnal continence between 80 to 70% of patients. Ureterointestinal stenosis, again, very variable, between 3 and 18%. Metabolic disorders, vitamin D deficiencies, vitamin B12 deficiency is something that is also frequently seen in these patients. One need to be careful about these complications. If we look at our own data, in the last 15 years, we've done over 300 radical cystectomies. And in vast majority, as you can see, about 250 patients had an ileal conduit. So this is one of the most commonly performed type of urinary diversion. Orthotopic bladder in about 52 patients. Continent cutaneous diversion in the form of Indiana pouch and small number in cutaneous ureterostomy, again, in a very small number of patients. Well, for orthotopic neobladder, it's important that you select your patient properly in terms of disease, and it should be local or minimally locally advanced disease with not more than N1 nodal involvement. The patient should not have any significant bowel resection because you'll be using about 50 to 60 centimeters of small bowel. Should not be any significant anatomical abnormality with proper liver and kidney function. The urinary sphincters should be properly functioning because otherwise there is no point doing a urinary diversion. With good functional class, and more importantly, the compliance, because if a patient is not compliant and doesn't follow regularly, then they're better off with an ileal conduit, which has very few long-term complications. Whereas an orthotopic bladder is a responsibility. And it's important that these patients realize that this is a responsibility and they come regularly. Otherwise, there are chances of long-term morbidity in terms of renal dysfunction, recurrent infections, etc. Pathologically, obviously, you cannot have urethral cancer or prostatic fossa or bladder neck involvement in women. The multifocal CIS, particularly close to the bladder neck, is again a contraindication. More than N1 involvement is another. And there are certain perioperative findings which precludes use of orthotopic bladder, and this includes a short mesentery or rectal injury. Short mesentery is something that I've seen in two patients, one of whom we were able to do a ileal conduit, and then subsequently he got reduced his weight and we changed his diversion to orthotopic neobladder. Rectal injury is again a contraindication too. Now, in order to improve the perioperative complication related to the diversion, it's important that in cystectomy is that minimal bowel preparation be done. So the classical teaching of extensive bowel prep is no longer required. However, two high colonic enemas are necessary because you need to have a clear rectum. So if there is any superficial injury or minor injury to the rectum, it can be primarily repaired rather than providing a colostomy. Education and counseling of patient of what to expect is again very important. Medical optimization, because a lot of these geriatric patients have medical conditions. So their glycemic control, their hypertension, their ischemic heart disease, etc., should be optimized before surgery. DVT is a real risk and can actually can have significant morbidity if your patient develops DVT. So subcutaneous heparin starting 6 hours before surgery and continuing until patient is completely mobilized. Compression stockings and early mobilization are the ways by which you can decrease the chances of deep vein thrombosis. Antibiotic prophylaxis is important because the patient has a lot of tubes and drains and stents inside, and the at least oral antibiotics should continue until all these stents and tubes are removed. Well, for the past 5-6 years, we have stopped using epidural anesthesia, which we used to use quite frequently for these patients. And now we go for the TAP block. So the transversus abdominis plane block, which really blocks the ilioinguinal and iliolumbar nerves, provides excellent postoperative pain control, and it is not associated with any significant complication. It can be done either in the form of perioperatively, which means that when you are closing your laparotomy, that's the time that you do it, or you do it preoperatively using anatomical landmarks or ultrasound guidance. In the postoperative management, angiotube should be removed in the recovery room or as soon as possible, because it really impacts the way the bowel starts to function. By avoiding narcotic, you improve the chances of early bowel recovery. So tab block with paracetamol and gabapentin is the standard. Nausea and vomiting prevention is important, so don't use tramadol and other medications which can cause nausea and other the other narcotics. So alvimapam is one medication which can be used. Neostigmine is another one. However, one of the cheaper ways to ask your patient to start off on chewing gum on the first day after surgery and start them on tea and yogurt on the second day after surgery, and mobilize them early, and that all prevents the ileus. So take out the angiotube early, mobilize your patient as soon as possible from the first postoperative day, and serve them tea and yogurt from the second postoperative day. And all these factors will help in early bowel recovery. Now, another thing which is being talked about is the different approach from the classical approach of transperitoneal radical cystectomy, in which what was described by Hautman and colleague, by mobilizing the colon, taking a wedge of peritoneum and continuing from above down. So Kulkarni and colleague some 20 years back described the extraperitoneal approach. And by doing an extraperitoneal approach, it really reduces the postoperative morbidity and decreases the gastrointestinal complication. So the initial part of that surgery is relief of the urethra and the sphincter meticulously right from the beginning, just like you do a radical prostatectomy. And then examining the overlying peritoneum at the end of cystectomy for its appearance and decision for its preservation or removal. So you don't really need to take a wedge of peritoneum and open up the peritoneal sac, so all the small bowel really flops into the pelvis. So what are the drawbacks of the classical approach? Number one is that you violate the anatomical compartmentalization of peritoneal and retroperitoneal space. So all your intraperitoneal organs like small bowel, etc., flops into the retroperitoneum. And this translates into increased if you do not use the transperitoneal, you'll significantly improve the morbidity related to the gastrointestinal tract from 15 to 5%, and the intestinal obstruction rate from 8 to 2%. And in this diagram, you can see that after removing the bladder, the peritoneum is inspected and it is closed. And the ureters are brought and carefully small bowel anastomosis is done. So the way we do it is that we start off like radical prostatectomy, do the endopelvic fascia first, divide the endopelvic fascia just like the first step of radical prostatectomy, and subsequently the puboprostatic ligament is identified and divided. After you've done the pure prostatic ligament, you do the take care of the dorsal vein complex. The centrovenous plexus is identified. You put your left hand, identify the urethra, and anything which is lying above the urethral anterior urethral wall is your centrovenous plexus. And it is carefully identified the space between the urethra and the centrovenous plexus. It is tied and divided. Once you have done that, in majority of patients, you can do bilateral nerve sparing, cystectomy. So apex of the prostate is identified, and you can see this is the prostate here. This is the apex of the prostate. The neurovascular bundles are really at 5 and 7 o'clock. So you isolate the urethra and from the neurovascular bundle, and you can preserve these neurovascular bundles. And once you have done that, then the posterior dissection continues. So rectourethralis fascia and the lateral, superior lateral, inferior lateral pedicle of the prostate is divided. So as you can see here, that the prostate along with the bladder, which is here, is completely isolated, and all this way through, this is a retroperitoneal dissection. Once you have done that, you can then take care of the superior lateral pedicle. If you think that the peritoneal covering on the anterior bladder wall should be removed, then you have to open up the peritoneum and take a wedge of peritoneum. If it is a smaller defect, then it can be completely closed. But this is how the traditional cystectomy is done. Now you see all these small bowel will be exposed to the pelvis, which is not lined by peritoneum. And as such, the bladder becomes irritable, the small bowel becomes irritable, and they either develop adhesions or they develop ileus. So part of the ERAS protocol helps in decreasing the complications related to radical cystectomy. And one of our proposal for nurse-led ERAS protocol for cystectomy patients was awarded the Best Presentation Award with a grant of €5,000 to conduct this study. This is our own functional and clinical outcome reported some years back. And we have noticed that about 90% of our patients were continent at day and night time. After radical cystectomy and orthotopic bladder, the mean bladder capacity at 6 months was close to about 400 ml, which is fairly good. The late complication rate was 17%, and that typically included bladder neck contracture, bladder stones, and incisional hernias. And over 80% of the patients have preserved renal function, and the overall survival rate was 80% at 5 years. The Clavian grade 1 complication after radical cystectomy and orthotopic bladder include ileus, nausea and vomiting, urinary tract infection, a blocked catheter. And all these, we have talked in details about how to prevent these complications. Intra-abdominal leakage from the anastomosis of the new bladder could be managed by diversion, either in form of foot catheter drainage or nephrostomy tubes. The postoperative ileus, again, is seen more in male patients and patients who are elderly and those who had significant blood loss. So how to avoid that, as I've talked about it, that NPO 6 hours for solid and 2 hours for liquid, and administering this commercially available Gatorade, which is a sports drink with an electrolyte, balanced electrolyte solution, is really good if administered up to 2 hours before surgery. Postoperatively, day 1 chewing gum, day 2 tea and yogurt, and you can start off with a full liquid diet from day 3. Now, this Aldinopam I've touched upon previously is an important medication, and it's important to understand how it works. What really happens that opioid, when you give opioid for analgesia, they couple with the G protein, and this receptor causes activation of the G protein with adenylyl cyclase. And that increases the potassium efflux, which results in hyperpolarization, and there is reduction in the pain. Now, this is what happens in the central nervous system. However, if you look at the GIP tract, all this results in the same cascade of events, with the opioid binding with the G protein and G protein complex causing adenylyl cyclase activation with the efflux of potassium and hyperpolarization. Now, this would result in decreased gut motility, and all these events are blocked by this drug called Aldinopam. However, it is expensive, and it's not easily available everywhere. So you need to alternate things like the regime that I have described. Cravian grade 1 late complication include non-compressive lymphocele, mucus incontinence, and retention, and the treatment is really based upon the complication. So the mucus is an issue, and they can be easily removed by even a cough and catheter drainage with bladder washing. The incontinence, again, is seen in patients who have not developed enough capacity to hold urine, and you should have a capacity of about 400 ml in order to completely empty and have a continent divert. So the prevention of infection and prevention of postvoid residue is important. For retention, until it resolves, patient can be on intermittent self-tap. Cravian grade 2 complication include anemia, which is badly tolerated, and in that case, you have to give transfusion. DVT and pulmonary embolism should be prevented as much as possible. If it does happen, you need to heavily anticoagulate your patient. Pyelonephritis, which can be prevented by keeping your patients on antibiotics until their tubes and catheters are removed. Among the grade 3 complications, you can have urethral catheter, which is accidentally removed, and it's a precious catheter. Anastomotic stenosis with urethroileal anastomotic or urethrointestinal anastomotic stricturing. Reflux is really not a major issue with orthotopic neobladders. So as long as your bladder capacity is 400 ml, there is no significant reflux with chances of renal dysfunction. The leaks, if there is an ileal leak, that's really a disaster situation, and a patient would require re-exploration and ileostomy, and the whole recovery is significantly delayed. For grade 4 complication like rectal necrosis, colostomy would be needed. If there's a rupture of neobladder, nephrostomy and indwelling catheters sometimes work, but if they don't, then you probably have to go in and repair these leaks. So one of our patient who came from outside town for orthotopic neobladder underwent an unremarkable radical cystectomy, and leak. So his bowel function was not getting better, and so he underwent a CT scan. The CT showed that there is a subtle leak from his ilioileal junction. And on exploration, we found that there was a small posterior wall leak from the ilioileal anastomosis. He underwent ileostomy, and then subsequent cystogram showed that there is the drain which was placed after ileostomy was actually indenting onto the neobladder, and it caused the leakage from his neobladder. He subsequently required a nephrostomy drainage, and after many months of conservative treatment, his leak stopped. So you really need to stop the cascade of events and one lead to another in these geriatric patients. So thank you very much for your attention, and I'll be very happy to respond to any question that you may have. So some of the questions were addressed during the presentation, and I'll be happy to take any further questions, queries, or comments. I see Dr. Khurram Siddiqui is here. Thank you, Khurram. Dr. Ananda is here. Ananda.
Hello, sir.
It's nice to have you.
My pleasure.
Good to see you. So I'm sure we are doing a much lousier job than you guys must be doing with your robots. And any comments?
This is a very good presentation, especially for those who are preparing for exams and trainees. I think this is something they need to use it for the revision. I am a pure endourologist. I do predominantly benign stuffs. I don't do much oncology, but wonderful job. I really thoroughly enjoyed the presentation. Very nice.
Thank you very much, Ananda. Professor Ather Rahman himself, very proficient surgeon and does significant cystectomies. Ather, if you want to share some of your observations or any points that you might like to add to.
Yeah, what I may not too much add, but I think it was an excellent presentation. I think particularly those who are really doing cystectomies, I think this is what, and I think your institute is a major volume in Pakistan, as far as I know. So I think it should be done by the major volume center. And I do cystectomies, but not, it's not a regular, but my main work is nowadays is stone surgery. But certainly this type of work should be done in high volume centers. And as the president of the PAUS, I think what we are planning, that we have given approval for the School of Urology. I think this should be a part which would be going into, and the junior trainees and those who are learning, I think they can view your talk and maybe others as well. So I think it's a lot of learning opportunities. So excellent talk, and I think you continue this work so that it is going to educate lots of the juniors and all the consultants as well. Thank you very much, Hammad. It was wonderful to listen to you.
Thank you very much, Professor Ather. And this will be a regular feature. So every first and third Saturday of the month, and we will have national and international speakers. Ananda himself does excellent job in terms of BPH and all the latest armamentarium in the management of BPH. Professor Ather, who is into our president, who is a great endoscopic laparoscopic surgeon. Dr. Khurram Siddiqui, I remember the time that we used to do cystectomies together. Again, he's into oncology with all his background fellowship trainings. So we're looking forward to talks and presence of all national and international speakers. And I hope this session will be of value to our residents. This talk and all the subsequent talks will be available on the PAUS Karachi website. And I'm really grateful to Aninda for converting them into YouTube videos and make this resource available throughout for trainees all around the world. So thank you very much and have a nice evening and a weekend, and take care, and hope to see you on the third Saturday of December.
Thank you, Hammad. Thank you very much.
Office.